So today we are going to start our Jharkhand State Society's instruction course. This has been given to us. This is a very important topic we have selected, hot debates in cataract surgery, because whenever we, in our day-to-day situation, we come across so many situations where there is a dilemma in choosing that right technique or right IOL. So in that case, when we in this after this course, it will be very clear to you after just seeing the pros and cons, which will be discussed, and after hearing the expert panel. So once first speaker will be there, the second speaker should be here. Okay. So now Bharti Kashyap, and next will be Dr. Vibhuti Kashyap's presentation. All is in podium 1. You please start shifting. First, Dr. Bharti Kashyap, pseudoexfoliation. Okay. Then Dr. Vibhuti Kashyap, this. Where should I go? Here or here? Presentation will be from Dr. Vibhuti. He will speak because he has not come. First, I have to speak. Yes. And timer set kariye. 6 minutes each. So in our day-to-day condition, we come across, it is not very rare to find pseudoexfoliation cataract, especially in rural condition, in southern India, it is more common with in advanced age. So pseudoexfoliation cataract with glaucoma and astigmatism, should we go for combined surgery with toric IOL? So I am speaking for toric IOL, and my opponent will speak for monofocal IOL with trap. आगे नहीं बढ़ रहा है, आगे नहीं बढ़ रहा है, आइए देखिए. Yes. So it is more common in rural condition, and we know that nuclear cataract, subcapsular cataract, they are all due to ocular ischemia. Incidence of cataract surgery is significantly higher. Iris subluxation, lens subluxation is 8.4 to 10.6%. 50% of the patients, they have glaucoma, mostly secondary open angle glaucoma. There is an increased risk of glaucoma by 10 times. There is a significant proportion of patients have astigmatism. 50% of patients have glaucoma, we already discussed, and this is the level 1 evidence that there is a significant astigmatism in pseudoexfoliation. So can we consider toric IOL implantation with phaco trap for patients with pseudoexfoliation cataract with astigmatism and glaucoma? Yes or no? Yes, we can do it. Trap is a very commonly done surgery, but before implanting toric IOL with phaco trap, there are certain pre-op evaluations of jonular weakness, which is very important, like shallow ACD, and in supine position ACD depends. And most important thing is when you do slit lamp examination, there is a gap between lens and iris. Poorly dilating pupil is not necessarily an indicator of jonular dialysis. There are certain per-operative considerations also, like good akinesia, never a tiny capsulorhexis, complete hydrodissection is very important. We should keep ready CTR, iris expanders, VR backup. And when we don't see any jonular dehiscence and we miss it pre-operatively, we can sometimes find it when we start jonular capsulorhexis, and we find there is a wrinkling of the capsule, and that is indicated of jonular weakness. At that time also, we can shift to monofocal IOL. So a CTR has a dual purpose, but there is no evidence to say all eyes with pseudoexfoliation require CTR. So if there is a progressive weakness of jonules, yes, it is there. So it may subluxate or dislocate, but whether monofocal IOL or toric IOL, then why deprive the patient from toric IOL and its advantage? This is a small video clipping. Toric IOL has been implanted and a trap is being done with the trabeculectomy punch. The flap is sutured, the conjunctiva is sutured. You can see the 6 years follow-up of the same patients. There is a little phimosis-like effect. And this is the Varion sheet 6 years back. And on the right side, there is a retroillumination slit lamp picture of the same patient in dilated situation. You can see there is a IOL is at the same position. Actually, the main important thing is we have calculated phaco-trab SIA in our hand. Mind you, I am stressing phaco-trab SIA, and we put phaco-trab SIA in all our situations. So this is a comparative analysis of refractive outcome of toric IOL in post-combined surgery SIA group and post-phaco SIA group in pseudo-exfoliation cataract and glaucoma and astigmatism in our hand. So in the the most important inclusion criteria is no pre-op and intra-op sign of jonular weakness, 5.5 dilatation, astigmatism more than 2 diopter. This was a prospective comparative study, single surgeon, tertiary eye care. Group 1 was 40 eyes, toric IOL with post-combined SIA. Group 2, 40 eyes, toric IOL power calculated with post-phaco SIA only. We found, based on centroid value SIA was calculated, we found that post-phaco-trab SIA was low, 0.21 and 0.23, and post-phaco SIA was 0.5, 0.54, because our primary incision is maybe because 150 degree and our trab is at 90 degree always. So this is the spherical equivalent, K1, K2, axial length, all comparable. Outcome measures photopic and mesopic UCDVA, BCDVA, spherical equivalent, intra and intergroup anterior chamber depth, residual astigmatism. So we found that comparative analysis of pre-op and 3 months post-op anterior chamber depth in group 1 and 2 was comparable. Intra-group comparative analysis of pre-op and 3 months post-op anterior chamber depth was also comparable. So post-op spherical equivalent was significantly better in group 1, that is post-phaco-trab SIA group. Post-op residual astigmatism was also significantly better in group 1. Photopic uncorrected distance visual acuity, photopic best corrected distance visual acuity were significantly better in group 1. Mesopic uncorrected distance visual acuity and mesopic best corrected distance visual acuity was significantly better in group 1. So after adding post-phaco-trab SIA, we can implant toric IOL at the same sitting with phaco-trab, resulting in optimum refractive result. For that, you have to calculate your own SIA for this also. And the post-op, it needs intensive post-op care, increased inflammation, IOP spikes, capsular phimosis. So all we need to shoot this triple problem is extensive discussion with the patient, appropriate meticulous clinical evaluation, and careful post-op care. Thank you. So my opponent is has not turned up. So Dr. B.P. Kashyap is the person who is standing here.
Good morning,
Dr.
everybody.
Vibhuti Bhushan.
Good morning, everybody. The presentation is not loaded, madam, and the same PPT was loaded on 4th. They are unable to get the PPT. And this time, I tell you, the audiovisual team of Echo Global have been very, very poor. The first slide never moved in any hall. We have to keep on reminding that the slide is not moving, slide is not moving. And the very simple thing, this is already preloaded there, and it is not coming here. So I am going to complain about this Echo Group. Aapka naam itna zyada hai, and everybody is paying you so much, and you are not able to perform your job. We will officially make a complaint against you. So friends, leave apart all these things. There are certain features. Number 1, pseudo-exfoliation. There are a lot of problems are there. Number 1 is a non-dilating people. Number two,
No. I said that prerequisite in my case
Yeah.
was a 5.5 millimeter dilatation.
yeah,
So let him finish.
Okay.
Okay.
it's a non-dilating people. Number one, it's a progressive disease. Number three, the patient tends to get glaucoma after some time, and there are a lot of deposits in the lens, and the zonal ligaments are very, very weak. Now, the question is, if you are doing a phacoemulsification, you have chosen that, and you find that the patient has got toric astigmatism. It needs toric glasses. Now, you have to see to it that in pre-operative time, everything is fine. The pupil dilates to the extent that you'll be able to complete the operation, number one. And number two, you'll be able to put a lens inside. So then you can start with the operation, you can proceed with the operation. But the question is whether you will be able to put a toric lens or not, whether you should put a toric lens or not. I would say, why put a toric lens? The opponent says, if you can put a lens, why not a toric lens? Because there is a progressive weakness of zonules. It will further move. And it will further move, and then your toricity is gone. So what is the idea of putting a toric lens? Number one, there are two things. Number one is zonules, and number two, the bleb formation. Can you assure that the bleb will be good and to the optimum? No. Sometimes the bleb are very high. Sometimes there is a flat, and sometimes the bleb do not even form. Then you have to do certain maneuver to make the bleb. So since the bleb is not constant all the time, whatever method you do, so the bleb may be bigger or smaller, and it will affect the overall diameter of the toricity of the cornea. So why put IOL, especially toric IOL? IOL, fine, because you have got all the prerequisites, because you have seen that the ligament is fine at that time, you can go ahead with the IOL. But why toricity? What will happen if there is a higher bleb? What happens if the lens give way? What happens if you have to readjust the sutures for the trabeculectomy? So in my view, the putting a toric lens is putting the patient into danger. If you have done your SIA, it's fine. If the bleb is formed uniformly, it's fine, but it will never form. And then there is zonal weakness. So in that case, I would suggest that putting a toric IOL is not justified for the patient.
Okay, then let's have an expert opinion.
So we have heard both the speakers spoken on the pseudoexfoliation and then IOL implantation. And what I could see, like Dr. Bharti Kashyap's presentation, she has shown very beautifully that her SIA, even after the trabeculectomy, was not that high. And it was almost comparable to the any phacosurgery incision. So that makes the difference actually, because if your SIA with the trabeculectomy, because if you are planning your trabeculectomy very well, and your incisions are absolutely on the steeper axis, because that is another thing, you can put the steeper axis incision. And so I think there is no harm in doing the toric IOL, because if the patient has a very high toricity, so why to leave the toricity patient and giving the glasses later on? So why not to put the toric IOL? The important thing is you have to basically assess the patient very well, like what is the stage of zonolysis or the pseudoexfoliation, because not all the pseudoexfoliation patient will show you a lot of zonular dialysis or zonular weakness. And if you think that there is a phacodonasis and very lax zonules, then yes, definitely you may consider in other way. But not too much of zonular weakness, or the SIA is, the toricity is very high, then you can consider toric IOL, definitely.
So I think just...
Sir, one point, sir.
Okay.
Even the creating a trabeculectomy, it itself will give rise to
Sir, you
astigmatism.
remember he was presenting for
So I think, first of all, a small pupil is not an issue, because we do toric IOLs in all these small people. And a patient has got a existing glaucoma, it always works better to do phaco trap than doing in a 2 stage. Because once you remove the cataract, some of the other, the shallowing of the chamber, all those problems don't take place. So phaco traps work very well. And in a pseudo exfoliation, usually it is a generalized weakness, not a localized weakness. So in a generalized weakness can be handled by putting the CTR. If it is a localized, then lens will get decentered to the one or the other side. If proper measures of Ahmed segment or others are not used. So that means if there is generalized weakness, and in fact, in all the cases of the floppy posterior capsule, in a hard cataract, in many cases you'll find when you put on a viscoelastic, the folds are not gone in the posterior capsule. That means there's a posterior junior weakness in those patients. So all the patients of posterior junior weakness, I put on a CTR ring. So that means when you are putting in a toric IOL pseudo-exposition, you can put on a CTR ring. Now coming to the as toric IOL, if the cylindrical power is less than 1 diopter, then there may be controversy and confusion whether we should put on a toric IOL or not. That too gets compounded if we are trying to put on a EDOF toric IOL, multifocal toric IOL. Because toricity gives you depth of focus. Same job is done by the EDOF or multifocal IOL. They give you depth of focus. But in both the conditions, some amount of contrast is lost. So if you are putting an EDOF lens and toricity is not corrected, that means patient is losing double the contrast. So whenever we put the EDOF lenses, we try to correct a low cylindrical power as well. I mean less than 1.7, 0.75. So in those cases, probably there could be a debate whether to put on a toric IOL or not, how much change, without going to our analysis of SIA, which is very good. If it is so, we can of course safely put it. But if it is beyond 1.5, you can definitely put on a toric IOL. And it's better to have at least diagonally 90-degree opposite incision, which will neutralize each other. That means your trabecularity is at 90, you put on a 180-degree on this side. That's the reason the SIA has come out down, because they are neutralizing each other.
Yes, sir.
So if it is 30 at 90, 120-degree. So if there are two incisions, one is causing flattening here, another is causing flattening there, they can neutralize each other. So there is absolutely nothing wrong. You can go ahead and put a toric in a more than 1 diopter cylindrical. Of course, in any case, when the complication takes place, even I put on a EDOF toric even in cases of PCR. So there is nothing wrong. And because I feel that these lens, removal of lens is a very easy option in the life. Do not be scared of explanting and putting in a fresh lens. If I put in when I motivate the patients for my multifocal IOL, I tell them, you have only one chance to be the spectacle free. I can remove this EDOF lens and make you monofocal any time in your life you want to be. But reverse is not possible. Because once the fibrosis takes place, I cannot put on an EDOF lens. So, a patient has got no monetary problem, go ahead, give him the best you can do for the patient.
Sir, I have a
And one
question.
important
Sir,
point
sir,
is like
एक
when
minute question है, not regarding this. I have a general question. Like whenever we do it off, so contrast is reduced. So even if there is a low cylinder, you correct because there will be a double reduction in contrast.
That's true. That is what he said.
So that's what. So if the cylinder is 0.75 and I am putting it off or trifocal, I will put trifocal toric even if it is 0.75 or 1 or 1.25, right?
The 0.5 and 7.5
only-
can be
only
corrected with the
whenever-
incision also.
Whenever
So I don't think
Just
like a
incision
0.5
by
or
carcuate,
0.75 needs.
femtoarcuate, 0.75.
What she's saying, 0.5 diopter per she'll put
No,
the toric
0.75.
even 0.5,
0.5.
whatever it is, see they are, whenever we are talking about toric IOL and in a low parameters, first of all, give the fluorometholone eye drops to the patient for a week and a lubricant eye drops.
What, sir?
Mild steroid and lubricant eye drops.
Okay.
You have to ensure that you are getting a consistent result of the same cylindrical power on 2 machines at least, that means Pentacam and IOL Master. and the refraction of the patient should coincide with that.
प्रिंट का है
Refraction, चश्मे का
Refraction.
number.
Okay.
Glasses.
अगर उसके चश्मे के नंबर में 0 है पावर एक्सेप्ट कर रहा है और मुझे सिलेंड्रिकल 0.7 आ रहा है तो मैं उसको टॉरिक नहीं लगाऊं. अगर उसके चश्मे में 1 आ रहा है और मुझे टॉरिसिटी 0.75 मिले तो मैं उसको 100% करेक्ट करूंगा. सो आई टेक व्हेनेवर दे
सर
डाउटफुल.
100% 1 और 0.75
नहीं, पहले बात जस्ट ट्राई टू अंडरस्टैंड बिफोर यू आस्क अ क्वेश्चन. Whenever you are trying to correct a smaller number, you need to be more than 100% sure. I have seen many patients where keratometry has shown 0 cylindrical power. Patient was using cylindrical spectacles, and at the end of them, he gets the cylindrical power. So there are many factors we don't understand. So if there is an alignment of the axis on a various machine, they are giving the same. That means this patient has got a very stable astigmatism, very sure astigmatism. Further, if you are getting the refraction also on the same axis and a same plane and nearly same amount or more than that what you are getting in a keratometric, you could be 100% sure that this patient is going to be happy after correction of the cylindrical number. Otherwise, there will be a residual number. So whenever you have got a borderline cases, then I go and check the refraction of the patient. Even when, because all the toric IOLs are not available in the exact power. So if you have got a confusion whether to use 1 or 1.5, you have got the keratometric value in between the two, 1.25. So what should I do? So in all those cases, I'll take the refraction of the patient also into the consideration. That means if the patient has got a high refraction, I'll take a little higher power of lens. Patient has low cylindrical refraction, I'll take a low. So in the refraction, we have been missing into whole of these calculations in all the formulas. So but in all my patients, I never used toric sheet of any company ever in my life. I decide myself, because the pentagram gives you differentiating at 1 millimeter, 2 millimeter, 3 millimeter with total K, the anterior surface K, and the patient's anterior chamber depth. So all I take into the consideration when I mark the toric axis and
And I think one very important point is when you are considering toric or the monofocal eye, whatever it is, whether you go for the in the bag or at the sulcus. Because if you see, actually, because if you have a lot of zonular weakness, and when you see the patient's anterior chamber depth increases a lot when patient is lying down, it means there is a lot of weakness in the zonules. So in these cases, I think it's always better to put the lens, 3-piece lens in the sulcus, and you can do the optic capture in any way. And that would give you more stability to the lens rather than putting the lens in the bag.
I'll not agree with that because we don't have 3-piece toric IOLs available. And the single piece, in this way, the pseudo expression is already there, iris is already friable. I will not suggest putting the lenses into the sulcus and do the toric. And this is a generalized jonular weakness. So generalized jonular weakness, there will be no irregular. If the rhexis is round and large, that means this capsulophimosis becomes very intense when your rhexis is small. Then there will be a stretch on the jonules. And even what I do is, suppose I wanted to make a rhexis large and it has become small. So, or it has become eccentric on the one side. So I want to have a capsular tension equal. I'll take a needle, and as we used to do in the ECC cases, once you have put the lens, I will puncture the anterior capsular rim so that their force of constriction is at the same circle. If it has become eccentric on the one side, you just go and give some next on that side 3-4, so that the force of constriction is there. So if you can cut and make it round, fine. If you have got a time, put on a viscoelastic. So normally just having a hydrocannula on the one hand, taking the nail on the other side, I'll give 3-4 nicks at different places so that that constriction is released from the very beginning.
If we consider just the monofocal IOL, then
Monofocal?
if we consider only monofocal IOL, like a non-toric.
So monofocal you can think over it, but I still, because if the bag is going to dislocate, whether put into the sulcus, you do the capsule access,
So
I don't think
if
because
you have a lot of
the lens,
phycodonasis and lot of phycodonasis, and
because still
then
the
in
lens
that
in the
situation,
bag,
I
Sir,
think it's
the
not better.
lens
topic
in the
is-
bag will give equal stress to the
Yes.
granules than putting the lens into the sulcus, which will not give any stretch, and the capsule. I mean, you are trying to stretch the capsule with the CTR and the lens both. So I think a stretched capsule is better than letting it go the way it wants to go.
Sir, do you put a CTR in all the toric IOL insidious exfoliation?
No, not in all. There is a there is two types of juvenile weakness. One is the anterior, another is the posterior, another is the pan.
Okay.
So in a hard cataract, and in many cases you will find that the posterior capsule is a little floppy. So in those cases, even if there is nothing else, I'll still put this CTR because there is a jugular weakness of the posterior side. Next time you go and watch, you'll find many patients where the posterior capsule is really very, very floppy, very floppy.
So
in
in
a
all
hard
cases-
cataract, aged patient. So even if there are no complication, I'll put on a CTR.
So in almost
No. Only not. I mean only 10% of the patients. Not that key routine. I will
Sir,
not give up.
when you see the posterior laxity.
Posterior.
Laxity.
Can
Okay,
we-
sir, we should move ahead
Sir,
because
I'll take another few seconds. So pseudo-exfoliation is a kind of graded thing. Anterior 3 findings will definitely help us to decide whether we should go ahead with the toric or monofocal. The amount of exfoliation, pupillary dilation,
Nothing
and
to do-
iris
no, no,
atrophy can give an
nothing-
indirect indication of what kind of jonular dehiscence is there.
Nothing to do with the pupillary dilation. Nothing to do with the
nothing I
exfoliation, nothing to do
presented.
with that.
Pupil dilatation is not an
5.5
indicator.
you took, ma'am.
No, I took 5.5, but I have said that prerequisite pre-op consideration is if pupil is small, then it is not an absolute indication of jonular weakness. You did not see.
No, I
Yeah, I
think the
saw that,
people
sure. I
people
agree.
size is out of equation at all because we have devices to dilate the pupil. And
सर आगे बढ़ते हैं नहीं तो छूट जाएगा सर.
सारा discussion
So the next topic is keratoconus with cataract, and Dr. Reena Singh is speaking for RGP contact lens with monofocal IOL, and Dr. Pooja Kumari is speaking for toric IOL, and Dr. Reena is a ex-RPC cornea surgeon. Dr. Pooja is also ex-RPC senior cornea resident. They are all working in Jharkhand right now. So 2 RPC people against each other.
I will not fight at all, ma'am.
Start, please, Reena.
Good
We'll
morning,
come
one
to
and
the
all.
consensus.
Yes.
Yeah, it will come in the favor of science and,
And one
patient.
judge is RPC.
Ma'am, debate will end in the favor of patients and science.
Yes, chalo.
Good morning, one and all. I am Dr. Reena Singh. Today I am going to speak about refractive rehabilitation of keratoconus patient with cataract with monofocal IOL and RGP contact lenses. So as we all know, before any surgery in keratoconus, the stability of the disease should be assessed as surgical intervention has been documented to cause progression in these cases. There are multiple sources of error in precise determination of IOL in these cases. So to improve outcome, there must be some addition other than IOLs sometime can be planned. So why toric IOLs are unpredictable and challenging in keratoconus cases? So there are various biometry challenges. Some are like refractive index error in keratoconus. Keratoconus has altered ratio of anterior and posterior corneal curvature. So standard refractive index 1.3375 is erroneous in these cases. There can be some instrumental error because of the pupillary offset. As the radius of curvature reduces, the effect of K error increases in these cases. There are difficulty in exact formula used in these cases, as there can be unpredictable effective lens positioning in these cases because of steep cornea, higher exit length, and deep anterior chamber depth. There are some tear film irregularity which also can affect the repeatability and reliability of K reading. So why RGP contact lenses in these cases should be preferred? As we all know, RGP contact lens acts as a smooth surface along with tear film contact lens, and it helps to reduce the irregularity of cornea. The refractive error and aberration in keratoconus is not always fixed or regular. It can be mixed, irregular, and high in quantity. RGP has advantage here over IOS that it acts as a pseudo-regular cornea by acting together with tear film lens and compensate for regularity of the corneal surface. It is available in multiple design and options to compensate for irregular cornea. Here there are some examples of RGP lenses that we can use in different kind of astigmatism and irregular astigmatism. The benefit of RGP lenses, the modern RGP lenses are very comfortable and easy to fit in extremely irregular cornea due to possible design modification that helps them to stay more securely on eye during sports and other activities, allow oxygen to pass directly through contact lens, retain shape even while blinking. has large coverage and choices, durability and deposit resistance also, extremely durable with little care, so RGP can last years, they can be less expensive in long term. The only downside is adaptation required to RGP in some cases, especially in those patients who is not using RGP before surgery. Why not toric IOL in challenging keratoconus cases? Toric IOL requisite in any case, including keratoconus, is detection of abnormal corneal shape, evaluation of corneal cylinder, evaluation of corneal irregular astigmatism, and evaluation of corneal spherical aberration. Here we have challenges in keratoconus that includes, in keratoconus there is high chances of irregular astigmatism. Regular astigmatism can be present, but determining the ideal toricity is ambiguous due to vertex shift or pupillary offset. Stability of astigmatism is also a problem. There are conventional method of keratometric measurement, which is not very good in keratoconus because of refractive index changes and negligence of posterior corneal astigmatism. Newer modalities does help in negating these 2 points, but they are more realistic in keratometric measurement, but will deviate from normal SIMK value, so they cannot be used in conventional IOL formulas. Is the true corneal refractive power or equivalent refractive power is an answer? Actually, it is not, especially in advanced keratoconus. Pupillary offset is there very significant in keratoconus cases, mostly due to Y offset, but offset values of both X and Y correlate significantly with the keratoconus stages. So mean arithmetic value and power vector for total corneal refractive power within 2 to 5 millimeter zone in various studies, it is found that it is very variable. Mean K astigmatism different at pupil and vertex. If manifest pupil estimation goes wrong, leave aside the axis changes, magnitude changes itself will cause huge surprise in IOL power, especially in toric. So IOL power barometry, another challenge is axial length estimation. IOL formula also has limitation in keratoconus cases because all these formula has been formulated for normal eyes, and still there is no comprehensive consensus about which formula is best even in mild keratoconus, so larger studies still required. Post-operative concerns are also there. The prediction of positive error after 1 month is highly low or almost zero in higher stages of keratoconus. Post-operative, another concern is rotational stability and progression of the disease. Rotation of toric IOL greatly depends on capsular bag size, axial length, and associated myopia, which is theoretically high in every keratoconus case. So coming to the conclusion, the toric IOL can be an option in stage or mild cases, but concern that cannot be compromised on the name of one-time surgical solution or biometric challenges, questionable stability of disease and IOL rotation. So I presume that RGP contact lens after targeting hyperopia in final IOL powers can be put on RGP contact lens because it compensates for corneal irregularity with tear lens, can be readjusted for IOL surprises or progression of ectasia, has wider range and design modification for irregular advanced cases of keratoconus. It is time tested, excellent reversible solution. Even in post-operative progressive cases, it's a solution with satisfaction. So toric IOL should not be put or considered in cases where patient with progressive disease, difficult refraction, or in whom there is a high difference between preoperative RGP contact lens corrected visual acuity and spectacle corrected visual acuity. So I conclude RGP contact lenses should be considered in high toricity and higher stages of keratoconus. Thank you.
Let's hear out on that, please.
Can we have the slides, please? So good morning, everyone. I'm Dr. Pooja from Tata Motors Hospital, Jamshedpur. So
पोडियम में प्रॉब्लम है क्या? पहले वो डॉक्टर कश्यप पे भी
यहाँ पे आके ट्राई कर सकते हैं डॉक्टर पूजा कम हियर एंड स्टार्ट योर
लगाओ यार,
प्रेजेंटेशन
खड़े हो
हियर
तुम लोग, बैठे हो वहाँ पे कुछ देख ही नहीं रहे हो यार। ऐसे बैठे हो कोई मतलब ही नहीं हो कोई करने से। तो कहाँ हो गया फिर?
यहाँ पे स्टार्ट किया यहाँ से ट्राई करो
तो क्या किया आप लोगों ने जब पहला नहीं चला तो?
मेरा वाला भी नहीं चला था सर। पहला वाला पीपीटी जो उन्होंने दूसरे फोल्डर में डलवाया हुआ था, दैट वाज 405 एंड दिस इज हॉल नंबर 3 सर।
अरे तू खड़े होके तू देख लो यार। तो कम से कम खड़े होकर देखो तो सही क्या प्रॉब्लम आ रही है। सब आराम से बैठे हुए हैं।
it's not showing. It's coming. It's coming. Okay, thank you. So I'll be talking in favor of toric IOL in keratoconus with cataract. So little bit of introduction. As we all know, keratoconus is a non-inflammatory corneal condition with onset commonly in early adulthood, which gradually progresses and often stabilizes later in life. The corneal astigmatism in keratoconus adds to further loss of vision when one develops a cataract, and we also know that in these patients, the cataract develops earlier than people who do not have keratoconus, and most of these patients are myopic, which increases their risk for cataract formation. And the magnitude of astigmatism in keratoconic eyes can be quite prominent and high, and eyes with keratoconus may have significant regular or irregular astigmatism, and toric IOLs are beneficial for eyes with high pre-op regular corneal astigmatism, and assessment of progression of the disease is very, very important before considering for a toric IOL. So this is the treatment algorithm for keratoconus with cataract. If we have a patient with stable keratoconus with cataract and he has a good tolerance with contact lens, then we can consider for monofocal IOL if the patient has cataract and he can continue the contact lens post-surgery. But if the patient has poor contact lens tolerance and he has mild to moderate keratoconus and keratometry is repeatable on topographer, then we can consider for toric IOL. Or if the patient is having irregular Myers on topography, then we have to consider for corneal regularization procedure, and we can also consider for ICRS prior to cataract surgery with monofocal or toric IOLs. In cases of severe keratoconus, obviously we have to go for corneal-based surgeries in the form of triple procedure, which includes penetrating keratoplasty with cataract surgery, or we can also go for sequential cataract surgeries. In that we can perform ICRS, DALC or PK, which is followed by cataract surgery. Coming to RGP versus toric IOL, in cases of RGP, the main factor is the cost factor, because there is a high cost for RGP lenses as compared to toric IOLs, and maintenance is also an important factor. And these contact lenses are usually not covered by insurance companies, so there is an economic burden to our Indian patients. And we also have a lot of side effects by using these contact lenses in the form of concretions, blepharoptosis, and a few patients do have allergies with contact lenses because of the preservatives and solutions being used in that. Some do present with allergic conjunctivitis, superior limbic keratoconjunctivitis, giant papillary conjunctivitis, and risk of infection is always there with the use of these lenses. High association of atopy and ocular allergies is seen in patients with keratoconus, and almost 50% of cases of keratoconus in India are associated with VKC. So these patients are very intolerant to RGP lenses. So I'm showing you two studies. In first studies, it was done to evaluate the long-term refractive outcome in patients with cataract and keratoconus after phacoemulsification with toric IOLs. This was a retrospective case series. In this, 54 eyes with keratoconus with cataract were evaluated, and they found that toric IOL showed good predictability in mild to moderate keratoconus, in which the keratometer reading was less than 55 diopters. In the second study, they showed the changes in astigmatism and corneal higher order aberrations after phacoemulsification with toric IOLs in mild KC. It was a prospective case series, and in 19 eyes the study was done, and they had implanted toric IOLs, and they found that after implantation of toric IOL, there was effective reduction in the refractive astigmatism without significant induction of corneal higher order aberrations. So keratoconus patients may have high axial length. So in those cases, we can also use CTR to prevent the IOL rotations. So we have to go for customized toric IOLs, because in these patients, the astigmatism will be very high. So correction of higher astigmatism will require customized toric IOL. So this is a small surgical video. Here we can see the implantation of customized toric IOL. So this is a virion-assisted cataract surgery. After removal of the cataract, we can see the markings, which is corresponding to the steeper axis. And in the anterior segment OCT also, we can assess the thicker part of the cornea and the periphery, because that was the safer area for putting the incision. And after implantation of the toric IOL, the axis has to be aligned. So here you can see in the left-hand side, the pentacam reading is showing around 13 diopters of astigmatism. And in the same patient, the biometry also has been done. So here also, almost similar kind of astigmatism is being shown. And after implantation of the toric IOL, in eye trace, we can see there is a significant reduction in the astigmatism. In this image, you can see the left-hand side is the pre-op eye trace. So here it is showing around plus 10 diopter of astigmatism, and after the implantation of the toric IOL, the astigmatism has drastically reduced, and only the residual -3 diopter of astigmatism is present now. So toric IOL cannot be considered in patients who have progressive disease and those who have difficult refraction. And if there is a high difference between pre-op RGP lens-corrected visual acuity and spectacle-corrected visual acuity, and patients who have advanced keratoconus who may undergo keratoplasty in the future are not the ideal candidates for toric IOLs. So take-home message is that it's a good option if the patient has ocular allergy and if there is no compliance with contact lenses. And if there is socioeconomic limitations and mild to moderate stable keratoconus, toric IOL is a very good option. Thank you.
So now we'd like to have expert opinion on this discussion.
Sir, can I take 30 seconds? Even the case which was shown here had residual -3. So you have not promised spectacle free as the toric people, as the toric was targeted to reach at least. So there is still contact lens or spectacle independency is there in this case as well.
So at least from -10 to -3, like
Yes.
7 diopter of
So
astigmatism
the
reduction
least
is there.
requirement of contact lenses or spectacle is still there. Reduction of toricity is still there, but requirement is still there.
Okay.
So it can also vary from case to
Very
case.
good presentation by both of you, and both of you have very nicely explained like where we should go for the toric oil, where we should not go for the toric oil. But if the patient is fit, like as you said, the keratoconus is stable, your toricity of the cornea is almost regular, which can be calculated very well. And nowadays we have the choice of making these customized lenses, because I have recently implanted one patient who had a 14 diopter of toricity, and biotech made the lens. And really speaking, because the patient did so well, absolutely 6 vision.
I agree, sir, if the regularity of cornea is there. So in my presentation also, if the regular keratometric value we can find, we can go ahead. But there's still chances that ELP will be different and the residual refractive
true,
error
because
will
you,
be there.
you have very
Yes.
nicely put all the points, but then still be considered, because if a patient has a 14 diopter of toricity and then
I agree,
cataract,
sir. If
So-
the patient has never used RGP before, it should be.
Wait.
Sure.
Let me summarize. I think because the mini scleral contact lenses are expensive, costing around 90,000 something, and the acceptance rate is less than 10%. That means you prescribe 10 patients, hardly one will be able to tolerate it. But in any case, if any patient who can tolerate contact lens, even before doing cataract surgery, patient is well off, I give them the trial of mini scleral contact lens, because the quality of vision that lens can give, IOL cannot match. There is no doubt about it, because the whole of the cornea irregularity is taken care of. But if patient is intolerant to the contact lenses, which is more often the case, when most of the keratoconus patients we see they are not putting on the contact lenses. Then a patient accepts cylindrical power in a glasses. So we tell the patient that what you are seeing with the cylindrical correction on the spectacles, you will not see better than that, what you have been seeing before development of the cataract. Again over here, the biometric calculation has to take into the consideration more of a refraction of the patient than any keratometric value or axial length calculation is giving it to you. Normally, the patient needs 21 diopter of power if he is emmetropic. If patient is say +4, so normally I will add 21, 1.5 to 1.5 to 1.75 of a factor, around 6-7 diopter more. And this patient needs 28 diopter of IOL. And my biometry matches around it, it's fine. Otherwise, I'll fine tune that should come closer to this. Same if patient is suppose myopic by -6 diopter. So if the normal is 21, if any other myopic of -6, will need around 16, 17 diopter of a lens. So my biometry is coming around that, it's fine. Other tweak my biometry. Again, because the keratometry is so variable at a different point. Again, because like many RK patients we see, those who see very well in spite of so much of a regular cornea. But there's some point in the cornea from where the rays are getting focused, like the multifocal lenses. There's some point in the cornea where the rays are getting focused, or all others are scattering around. So the proof of that is what patient accepts on these spectacles. So patient is accepting 110 at the axis at the spectacle, whatever keratometry is giving, I'm not bothered. even if it's 50-degree off axis, I know that this patient is happy accepting this cylindrical at 110 axis. Period. So I'm not worried about keratometry. All irregular cornea, spectral prescription and refraction is the topmost criteria for deciding the toricity and the IOL. But of course, as I said, now the options are available for the customized lenses. So if you are having the cylindrical of more than 6 diopter, and patient if has got a 14 diopter, then probably you will not be able to correct. A patient may not be as happy. Of course, he'll be happy because half of it has been taken care of. But it's better to, if patient has got more than 8 diopter of spectral acceptance, then I'll go for the customized toric IOL. Because 2 or 3 diopter leaving is okay. Because if the spectacle is up to 3 diopter of cylindrical, the spectacles, there's not so much a prismatic effect when patient is moving the eyes here and there. So up to 3 diopter of the cylindrical on the spectacles is well tolerated by all of us. When it goes beyond 3, the tolerance becomes a problem. So if the available lenses, if I can bring down the cylindrical power to less than 3, I'll go with the available lenses. What is available? Patient comes, I operate and chapter close.
Sir, RGP lenses of 9.5 to 9.35 base curve and diameters are more used in keratoconus. The semi-scleral and scleral lenses are for extreme cases who is totally not fitting on the normal RGP lenses.
Okay, how many
lenses,
keratoconus patients have you seen which are using the contact lenses?
Sir, for my around 6-year training, I have seen almost 20-30 on every 2 weeks a day. I was posted in contact lens clinic, so
So the question is
and
not question
still
is
following up some
so if
cases
there are
in
a lot of
Ranchi as
practitioners
well.
sitting over here. So if I see 10 patients of keratoconus, hardly one will be there who is using
So
the
periphery it
regular
is
contact
very
lens.
rare because RGP fitting
So-
is not
so-
available,
no,
but
no, no.
in center
So-
it is there.
No, don't tell me it is not available. Now the in Delhi at least the people come, they give you the share of the money, they come and do the fitting and do everything. So that is not a problem. Fitting is available freely, where the people are roaming around with the kit and they do it everything. So it's not a problem of the fitting, but the tolerance and maintenance. Many patients have purchased those lenses at a very high cost,
I agree.
and
I
then
agree.
they discard it.
Absolutely.
And so the best is if the patient is not able to tolerate the contact lens, if his vision improves with the cylindrical number in the glasses,
next karte
go ahead with the toric.
Thank you so much, sir.
So we should move forward because time is less. So next speaker is, the topic is unilateral cataract, and Dr. Nitin Dhira is for the motion monofocal IOL, and Dr. S.K. Mitra against the motion trifocal IOL. Nitin Dhira is a cataract and glaucoma surgeon in Jamshedpur Eye Hospital, Jamshedpur, and Dr. S.K. Mitra is Director Dristidan Eye Hospital, Jamshedpur. Both Jamshedpurian.
Okay. Good morning, sir. Good morning, everyone. So, we all know that since the time man has learned to critically argumenting for something, a debate has always been regarded as a hallmark of human intellect. In almost all the debate, what we see is at the end of the debate, we come to some conclusion, except in one never-ending debate on man and a happy life. So married life. So coming to the scenario under my debate is, what is presumed is the other eye is absolutely normal in unilateral cataract, and a refractive lens exchange or presbyopic phakic IOL is not under consideration of neither the surgeon nor the patient. So if you look at the etiology of unilateral cataract, the congenital syndrome and the pediatric age group are the most commonly seen in the patients. And in younger adult or the adult, the trauma is the commonest entity. But the reason is not known, but in a significant proportion of the idiopathic patients where we are seeing the idiopathic reason for the unilateral cataract is also very common. So these are the subsets of patients where I will try to convince why I will go for monofocal rather than multifocal or trifocal lenses one by one. So what is the essential criteria for giving a patient trifocal or multifocal? We do not want to see any surprise in the residual refraction or the resting residual refraction when we have implanted the trifocal lenses. So in pediatric population, what is most challenging is getting biometric, right biometry, because the eye is weird, and there are some of the biometric surprise are there, and we do not have consensus over how the eye will behave even after the surgery. So after the surgery, even if you have implanted the lens, there is a changes in the shift in the refraction of the patient's eye. So if you will implant multifocal or trifocal, and there will be residual, the refractive error, then the condition will be more devastating. So this is the subset of the patient where in unilateral cataract, definitely I'll go for monofocal lenses. Coming to the traumatic cataract, we all know that assessment in trauma is difficult and challenging because the impact of the trauma in traumatic eye is, there are 7 rings of trauma in the basics we used to read. So starting from cornea to sphincter tear, which will lead to permanent, mid-dilated pupil, and the trauma in the canalicular system, which will later on give rise to glaucoma, and subtle injury to the retina, parafoveal region will lead to lessen contrast. So these are the another subset of the patient where I will consider a lot before implanting multifocal, and it would be safer to give monofocal if the patient is having unilateral cataract, because the other eye is absolutely normal and patient will keep comparing with the other eye. So my take here also will be monofocal against multifocal. The most challenging debate is if the patient does not have any such kind of difficulty, and why I will choose monofocal rather than multifocal is based on the psychological status definitely of the patient. If we see that the patient is of that type A personality and there is a chance that patient will keep on comparing after the surgery. Since the other eye is absolutely normal, and we know that whatever be the technology, multifocal is going to have some of the negative effects in terms of reduction of contrast and halos and glare. So if I believe that the patient is that category of psychological profile wherein he'll keep on comparing his vision or the profile with the other eye, then I'll think over giving monofocal rather than multifocal. So to conclude, I'll say that case assessment is very, very important. Rather than just jumping to multifocal in every cases is not a good idea. Long-term implication of the case and judiciously implanting the lens is very important. We should choose the best for that particular scenario, and of course it should be justified by science. Thank you.
SK Mitra against the motion for trifocal IOL.
Good morning, all. Good morning, all. It is very difficult to convince actually to people to go for the trifocals, but I have no financial interest, and whatever I will be speaking on my personal opinion, backed by literature and personal experiences. So today's scenario, there are the use of mobile or smartphone. The 84% of people are using mobile and smartphone. 70% own a computer, and 57% use a tablet on a regular basis. It's a study of 55 to 64 years old people. And it is very difficult to argue and convince, but I will try to justify my statement. The various presentation of unilateral cataract, as Dr. Nitin has already spoken, it is associated cataract in congenital syndrome, secondary cataract, traumatic cataract, posterior subcapsular cataract, pediatric cataract, idiopathic cataracts. The unilateral cataract, there are different causative factors. It is asymptomatic aging, glaucoma or uveitis. Rate of progression may be different in prolonged exposure or ultraviolet radiation from sun or smoking. Corticosteroid, diabetes, trauma, usually younger patients, more adaptable, and more than 50 years of age, a second eye to be done at an earliest. These are the various presentation of the unilateral cataracts. So each and every patient asks for spectacle independence. They got a common question, and where he has to use lenses and spectacles after the operations. That is a very beautiful study in the literature I found. It says unilateral implantation of trifocal IOL is well tolerated with good patient satisfaction assessed by visual function. 14 questionnaire in subjects to have cataract in one eye, encouraging single eye surgical procedure in this particular group of patients. The one more study, it says this meta-analysis of 13 unique clinical studies demonstrated that at least 9 out of 10 patients receiving trifocal IOL during the cataract surgery can expect to achieve complete spectacle independence. So the congenital cataract, exclusions in this group is associated with glaucoma, retinal pathologies, and systemic problems. Trifocal IOL implantation should be considered as an alternative to monofocal lenses in selective cases of pediatric cataract also where amblyopia is not expected. So there is one more study, it is found in the literature in case of pediatric cataract. In careful selected pediatric patients with traumatic cataracts, trifocal toric intraocular lenses may offer some benefit over the standard monofocal lenses, it says. This is a study of visual performance in monofocal, accommodating and multifocal intraocular lenses in patients. These are the different lenses which I use in the study. And there is 87 patients of around age of 40 to 70. It concludes that multifocal IOLs provide better stereopsis, higher spectacle independence rates, and satisfactory functional vision over a broad range of distance in presbyopic patients with unilateral cataract compared with the monofocal and accommodating IOLs. So I'll skip this slide. So there are the recent technology and the advanced technology shows that trifocal IOL, it is tried with EDOF, had higher balance contrast in comparison to the traditional trifocal. The MTF peaks are almost equal in 3 different foci. So the new generation IOLs of trifocals with which is EDOF with tri, they are super Gaussian profiles, and this gives minimum glare and halos. So light distributions is, you can see the hybrid technology of EDOF with tri or multi is there's a continuous vision across the entire range. So in conclusion, so these are the different light sources. If we see the violet filtering added to the lenses now blocking the high energy violet wavelength improves the driving vision quality and reduces the scatter. The people-side independence of IOL contributes to the best low light performance compared to the leading trifocal IOLs in the new group of trifocal patients. These are high myopic patients has gone for the trifocal IOL and S6, N6 which I have got. In conclusion, consideration is operating the other eye at earliest is if possible. Patient wanting for the refractive lens exchange, light adjustable lenses and spiral lenses also come into the market to minimize the dysphotopsia. Unilateral implantation of the trifocal IOL in patients with unilateral cataract could provide good distance, intermediate and near vision with good patient satisfaction and vision related daily activity performance regardless to the presbyopic status of the fellow eye. So treat the patient as per the requirement, should not be a biased decision and follow blindly. Patients should be provided with what is the best in today's scenario. Quality should score over the quantity of the surgery. Decision should be backed by proper evidences, and for spectacle independence, trifocal IOL is a very good option. So we have best skill, best technology, best setup, best machine, best options of IOL, high expectation of the patient, so why to compromise? So you have to choose which one you going for the newer era. Thank you very much.
Thank you very much, and wonderful presentation by both of you. And you have very nicely put the line in the conclusion, treat the patient as it is required.
Yes,
See, you have to actually evaluate the patient of the unilateral cataract cases, and the important evaluation would come. The age of the patient is very important, because one of the criteria what you have put in unilateral cataract is the congenital or the pediatric cataract.
Yes.
There, the whole scenario will change in decision of the IOL. But if it's a traumatic cataract or later stage cataract age, which is more than 14 years or 15 years, then your decision would differ. And considering monofocal and trifocal IOLs in unilateral cataract, because trifocals have been put, because you have to, in one way, give the patient, because otherwise there won't be any good coordination of the two eyes, because if you are giving just monofocal, a patient will still need the reading glasses for the other eye. So better to give trifocal or EDOF IOLs would be much better in this situation. And the patient's demand is also very important, because the patient, what patient expects, like whether patient, and it depends on the refractive error of the other eye also. If the patient is already using glasses for the other eye, then the things will be different, because then you can give the monofocal IOL with the overcorrection, undercorrection, matching the other eye, so that patient have a, if he has a myopic other eye, then you can make this eye also myopic, so that patient has a reading vision also. So many factors to be considered in deciding the.
So what is
the
your
IOL.
take on this new lenses, the new advanced monofocal lenses like spiral lenses has came to the market? With
This
the
spiral lens, I
asphericity in
think,
the posterior
has just
surface.
recently introduced, because we haven't used it. But yes, definitely these monofocal plus IOLs are doing very well, and we have seen with monofocal plus IOL patients are getting a good intermediate vision also.
Actually, sir, I have used the MF with tri, and that is good, very good. Sorry, sir.
I think debate about the whether we should use the multifocal in a unilateral cataract or not. So the primary selection criteria remains more or less same as in cases of bilateral cataract implantation. We all know that the multifocal lenses work better if implanted in both eyes than in one eye. So if the patient has got a high refractive error in the other eye, that means myopia of more than 3 diopter and hyperopia of more than 2 diopter, these patients will happily go for refractive lens exchange in the other eye, seeing the advantage in this eye. But if the patient has got nothing in the other eye and is still accommodating, he may not be very comfortable with the multifocal IOL, and you have got to convince him in a longer run, because you developed a cataract in this eye, you may develop the cataract in the other eye. And so beyond 40, the acceptance is easier, because patient is already using the presbyopic correction, is happy not to have the reading glasses. Below 40, you have got to really weigh the patient. So far as in a pediatric age group, multifocal and toric IOLs are concerned, even a patient biometry is a myopic shift, we know that at least he is using only one glasses for near and distance both. And at a later age, when he crosses age of 18-21, LASIK can be done, his myopia can be corrected. But multifocality cannot be given afterwards. So that means if we feel that there is no component of the amblyopia, that means the patient has got a congenital cataract with the amblyopia, I will not like to put on a multifocal IOL, because first priority is to treat the amblyopia. So why to have a loss of contrast and defocused image over there? But if patient develops a cataract at the age of 5, 7, 8, for any reason, that means the amblyopia has been taken care of. Patient has got a good visual potential. I'll go ahead and put in a multifocal IOL. So that if patient wants later on, you can make him totally spectacle independent, or at least he does not have to use the progressive glasses at a younger age. So far as the toric IOLs are concerned, they are even more dicey in this situation. And toricity again can be corrected at a later age with the laser, but multifocality cannot be corrected. And so the corneal toricity keeps on varying. So in not less than 3 years of age, I'll put on a toric IOL. I'll prefer child at least to be around 10 years of age to use the toric IOL. If it has got a very high astigmatism, I can go for 5, 6. So toricity I'm more worried about, because that fluctuates more. Multifocality and toricity can be corrected later on as well. Myopia can be corrected on later on as well, but multifocality cannot be given later on. So we can go for toric multifocal, being little cautious about it. And so far as the new lenses are concerned, one very basic principle is that more the addition, more the problem. That means any lens which is giving you 3 diopter addition, which is called more problem, 2 will cause less, 1 will cause less. So the modern day lenses, we still, the basic reason that we are having so many variety of things, that means there is nothing perfect as of now. We started our multifocality journey with this central for the near. It was thought that the people comes to small wide reading. Then we realized the distance vision is more important. So we made the central part for the distance and peripheral links we added for the near. Now it's again going topsy-turvy. Refraction based lenses were there. Then came diffractive, where everybody criticized the refractive optics. Now we are coming back to the refractive optics. So whatever technology they are trying to use is trying to confuse the defocus of the images. So whether it's a pure C, whether it's a VVT, whether it's a spiral, there is going to be no magic. There is going to be no magic because all the time two images are going to be there. So there is always some amount of confusion. How much we compromise and how much depth we take. Like if you see, I have explanted a lot of synergy lenses. Patient will see N5, 6x6, but in real life he was very, very unhappy. But hardly I removed very few symphonies. I have not removed any VVT till date. And pure C I don't think will cause any problem. So I'm more worried about that patient should not come and trouble us and keep on sitting and explaining him.
True. It's actually the contrast and the halos, which is the biggest problem in these multifocal
Halos
trifocal
and
eye.
glares are more important.
Halos are still patient can adjust with, but the contrast is the biggest problem because the synergy lens sir was talking. All the synergy lenses patients, the basic complaint of theirs is contrast. So whatever they see is not the distance vision actually because it's not clear. And by any chance, if patient has a synergy in one eye and something else in the other eye, then he will trouble you like anything.
But
because
not
you'll
like
always
this.
keep on
If
comparing.
time permits, can I speak for a minute more?
Yes, yes, sir.
So I had a patient, Sadarji, he never wanted to use glasses, had -1 diopter of refractive error with the eye hands. Excellent intermediate vision. But he was very unhappy. He wanted near and distance both. He researched a lot. So I explanted that IOL and put on a VVT IOL in that eye. So he was very clear कि सर distance तो बहुत अच्छा हो गया लेकिन intermediate ना eye hands के साथ better था with the -1 reflection. So he said कि okay now what lens in the other eye because कैसा अभी मैं पढ़ नहीं पा रहा हूँ. पढ़ना भी है. मैं देखो अब एक ही option है कि I'll put on a synergy in the other eye. है नहीं? Now you have got all three IOS inside your eyes. Then you decide after putting the synergy, should I remove the VVT and put synergy there, or should I remove the synergy and put VVT here, or you will be happy with one synergy and one VVT. So we went and with a very clear explanation, if you don't like synergy, if you feel synergy is better, if you want other eye, I'll change to synergy. If you want no synergy, it's troubling, I'll put on a, cut it and remove it and put on a 50. So, but that patient was quite happy because the synergy was giving a very good near vision and VT was giving intermediate vision and both the IOLs were giving excellent distance vision. So there are patients who accept and I'm very bold about it. I mean, I will anytime patient says, I'm not happy, I'll cut it, remove it and put whatever you want.
True. Thank you very much, sir. This is good. Nice learning.
VT in the other eye. And first he had eye hands with the -1 refractive.
So we should proceed
Thank you,
further
sir.
because without any delay. So now the next topic is 50-year-old with clear lens wants a spectacle independence. So first is Dr. Vibhuti Bhushan speaking for presbyopic IPCL, and against the motion Dr. BP Kashyap for clear lens extraction. Who is speaking first? First you? किसका अपलोड है? First clear lens, then IPCL. First clear lens.
presbyopic IPCL है ना?
करो.
Good morning, everybody. The topic is 50 years old, clear lens. So there's no mention about any refractive error. So I presume the patient is emmetropic. He is 50 years old. He has a clear lens and he wants spectacle independence. So when a patient comes, these surgeries are not forced surgeries. The patient they want spectacle independence, so we have to give them the options. So there's no financial interest. My choice will be a presbyopic IPCL. My reasons are, why to disturb a clear lens? Why to disturb the optical system of the eye, the natural optical system of the eye? And we have got a reversible procedure, which is, the predictability is better. There is a rapid visual recovery. The adaptation is very fast. And we always give the patient a chance for a better option in future. When we do refractive lens extraction, cataract surgery, the most dreaded complication is RD. In younger patients, there is a high risk of PCO and PCR, CME, because these patients generally don't have PVD. The 50-year-old patients, we don't get many patients with PVD. So, and retinal detachment can occur days, weeks, or months after the treatment, and there are feared postoperative complication of RLE. It's postulated that the pseudophakic RD occurs as the reduction in the lens volume draws the anterior hyaloid face forward, with vitreous-based traction resulting in retinal breaks. And in cases of patients without PVD, so the incidence is more. The debate of refractive lens exchange has been there since last couple of decades actually, and still it has not resolved. This was published in 2005. Then we have many reports in 2020 or 2019 in the last 4 or 5 years, which identify young age as a very important risk factor in cases of clear lens extraction, which can lead to RD. There are many studies. The most modest increase is reported by Shiu et al., who in their final follow-up study found a relative risk of 2.69 for patients aged under 50 compared with those aged over 60 years. And the largest age-dependent risk modification is reported by Pitosis et al., who found those aged under 60 had a 40-fold greater risk of pseudophakic RD than those aged over 80. It does not mention 50 years, but we can see how age has a definite bearing on the incidence of RD. Jerem et al. Note that above the age of 50, the risk of RD drops exponentially by just over half by each decade. This was published in November 2024. They identified they have charted the effect of axial length and as well as age. So we can see in the less than 60 years of age, the incidence of RD is 2.4%, and in between 60 to 75, it drops down to almost 1/3, to 0.65%. In younger patients, the risk of PCO is much more, and it is again, it needs YAG capsulotomy, which comes with its own complications in cases of younger patients without those who don't have PVD. Fluorescent flashes, CME, raised IOP, and IOL pitting is another major issue. So, do we have any better option? Presbyopic IPCL IOL is the answer. Why? Because it's a reversible procedure. If the patient is unhappy, we can remove it, and we know that how easy it is to remove an IPCL as compared to an implanted IOL in the bag. The available reserve procedure is still left. It gives a clue to choose an IOL when needed. And if we have to change, if we have to go for a cataract surgery later on, we can always choose on the basis of the experience of the patient, whether he was happy with the diffractive or EDOF variety of lens. It has a better visual outcome, and there is hardly any adaptation time. There is the recovery is immediate. The wow factor is there. No neural adaptation time is needed, and it is an adjuvant to the natural lens. We are not disturbing the natural optical system of the eye. And the most important factor is that it gives an opportunity for a better technology. A 50-year-old patient with clear lens, we can safely say that around 10 years, more than 10 years opportunity he has got. And we know just now the discussion was there that how fast the things are evolving. We still don't have any perfect trifocal, perfect multifocal lens. So what lenses we are using now, we are not going to use them 5 years, 10 years down the line. So we definitely know that we can give a better option to the patient in future. So if the patient comes to me with a 50-year-old patient comes to me with a clear lens, I would explain him both the options. If the patient chooses one, fine. But if he asks me, what will you do? You decide for me. Then my preference will be a reversible and a less invasive phakic IOL. Thank you, sir.
Now expert panel, please. Okay, yes.
कश्यप एक मिनट में बोल एक मिनट बोलना तुम्हें एक मिनट टाइम दिया जाता है नहीं मेरा तो प्रेजेंटेशन हुआ नहीं भैया छोड़ दो 9:15 सेशन खत्म होना था 2 टॉक और हैं
हाँ ठीक है, मेरा जरा स्टाइल लगाइए, अब मैं 1 मिनट बोलूँगा. My friend, Dr. Vibhuti, you missed the, the meaning between the lines, because
अब discussion नहीं
it is a refractive. Patient has some problem. He is using glasses, and all your references they refer to the myopic patients and the retinal detachment. You compared the anteroposterior diameter of the lens of the eye, or myopic. So how do you say that the patient was spectacle free and he wants a presbyopic glasses? Now, tell me one thing: if the patient has got a hypermetropia, the anterior chamber is going to be shallow. There will be crowding of the angle. Where will you put the IPCL? And the company says for its own sale that you can go up to anterior chamber depth of 2.8, but I'll never do it if it is less than 3 millimeters. And even in uncomplicated cases, everything is fine. When you inject the lens inside, many a time at the last moment, the IPCL they flip off. They turn it upside down. Then you are in trouble. You have to take out the lens, and there is a lot of endothelial damage. Of course, you can remove it, but it has got its own problems. But in clear lens extraction, absolutely no problem. All you have to do is check the retina, check the retina, check the retina. Advise the patient to come for a follow-up, a regular follow-up. Explain the patient that these are the problems that can occur to you, that, if you get a floaters, if you have any diminution of vision, report immediately. So, I will say that you take into consideration all the investigations. The formula for the IL power calculation is very, very important. And then during the operation, all you have to do is you have to be very, very careful about the procedure, like and mind you, in hypermetropic cases, the patients are not happy with the glasses. Somebody prescribe him +4, somebody prescribe +1. The patients using contact lenses for the hypermetropia, they're also not very happy. But you give them clear, if you remove the lens and put the intraocular lens, the patient is very happy. While doing clear lens extraction, you have to be very, very careful that every time you remove the lens, you have to put the viscoelastic inside. A bimanual irrigation aspiration is very, very important. And always hydrate the wound before you withdraw the irrigating probe. And I always inject a little air at the conclusion of the surgery. Well, there might be some complications that can occur, which is very normal. There might be intraocular lens dislocation, there could be a hemorrhage, there could be capsular rupture, xenodialysis, malignant glaucoma, suprachoroidal hemorrhage, and bone leakage, and retinal detachment. So before you do the surgery, you check the retina, you treat the retina, call the patient. Immediately before the surgery, you tell the patient that there might be a chances of retinal detachment. You have to come for a retina examination. During the operation, you talk to him. At the time of discharge, you talk to him. And the patient, when he goes back, you again tell them that you have to come for retinal examination because that is the only danger. So, think.
We will not take up discussion
Thank you very much.
because the time is up. Now I invite Dr. Suja Samanta and Dr. Nilindu Mishra.
So just let them come. By the time they come, there's one additional point. Even the 50-year-old lens has got still enough of accommodation left. And even 60 years, 70 years, if money is not a consideration, then phakic IOL is better, but still the phakic IOL have to prove its merit. As of now, we have not used them enough, so it will take some time. But otherwise, the phakic IOLs, if they are as good as the IOL, then probably phakic IOL will score over the IOL.
Important point is like,
Just 2 minutes because now Jepto is hardly available. Jepto is out of the market now. जेप्टो है ही नहीं है, अवेलेबल कहाँ है? है जेप्टो है, मिल ही नहीं रहा मार्केट में। इम्पोर्ट किया तुमने? नहीं नहीं, कॉम्प्लिकेशन नहीं है। तो यार, we have to respect the timings.
Good morning, everyone. So whenever we have to do our Rexis, capsular Rexis manually in an intumescent cataract, it's challenging for any surgeon, however expert he is, however skillful he is, because of the very fact that partially liquefied or many a times fully liquefied, the lens cortical matter causes high lenticular pressure, and what we take up as a normal case, case can land up into complication. The moment we start giving a nick or puncture in the center, the fluid tries to egress, and that can lead to situations like this, Rexis run out, or even in extreme cases, Argentinian flag sign, and the whole surgery can be catastrophic. There can be nucleus drop, etc. A long list of complications can follow. And even if the surgeon is very skillful, somehow manages to do away with the Rexis, he may not achieve a proper optimal result out of the Rexis he wants to do, because now we are in the age of implanting premium IOLs, in which we need a perfectly centered Rexis and with a proper size and predictable in all situations. So what is the solution? The solution is a time-tested device, and it's known as Zepto or Zepto PPC. It's a precision pulse capsulotomy device. Basically, it consists of a handpiece. It's just a silicone foldable handpiece with a ring inside, and that ring is very soft with a high memory, and that can be controlled by a push rod, and there's a console which controls the firing of the energy, and it creates vacuum. The procedure has a very short learning curve. It's very simple. You insert that handpiece through that micro incision or whatever be the incision size, and once it is inside, after proper centering and a proper apposition and the vacuum is created, when there is a firmly stable inside, you fire the energy, and that thing is done. It's simple as that. And after this procedure, this is the video I would like to show the same thing. You insert it, you unfold that cup inside, and you then, using that Purkinje image, you properly center. And once you are confident that it is properly apposed, you gradually apply vacuum. And when the grip is firm, energy is applied, and that does the process. It is as simple as that. And out of this simple procedure, what you get, this kind of capsular Rexis every time. There's no ifs and buts. A properly centered, properly sized capsular Rexis every time. And so, and even in cases like a small pupil or even in corneal opacities, you don't have to think twice whether you will be getting the same result. So I advocate this procedure for an intumescent cataract every time. Thank you.
Dr. Sujay Samanta is a very high volume cataract surgeon in Hazaribagh. Sir, you all have enjoyed his hospitality, and you all have you have enjoyed his hospitality also. He is the local organizing secretary. He was very good in Devghar, Baba Nagari, the 12 Jyotirlinga place, and he's also a high volume surgeon. Okay. थोड़ा intro बनता है.
Yes. Good morning, everybody. Argentinian flag side are self-propagated radial extension of the anterior capsule, which starts after initial puncture of trypan blue stand anterior capsule in intumescent and pearly white cataract. As the the disruptive force act along the linear margin axis of the tear. It shows that other than along with the high lenticular pressure, the linear cut is also responsible for the extension of the tear. Swing needle microcapsular axis capsulotome has a small, sharp and pointed tip which creates a round hole with continuous circular margin without any free edge, and that's it prevents and against the disruptive forces and thus this prevents the extension of the tear. The round tip has 0.75 mm in length, 0.5 mm bevel, and 0.6 mm in diameter. The round hole in the center created by swing needle microcapsulotome acts on the same principle as continuous curvilinear capsular axis. We can say the free edge created by sharp needle capsulotome and swing needle microcapsulotome. In cases of intumescent cataract, as there is high intralenticular pressure, which are responsible, not only the high intralenticular pressure, but also the linear cut is responsible for the extension of the tear. That's why by making a central round hole by swing needle microcapsulotome, just it creates a decompression. As the cortical matter comes out, it decompresses the anterior capsule and decrease the intralenticular pressure prior to, it just equilibrate the intralenticular pressure prior to the completion of the optimal size capsular axis. In cases where there is pearly white cataract with liquefied cortical matter, high intraocular pressure, after making a central round hole through the swing needle capsular axis, swing needle capsulotome, we can just tap the anterior capsule to decompress the capsular bag and decrease the intralenticular pressure prior to completion of the optimal size capsular axis. Just we are decompressing the bag to decrease the intralenticular pressure, and the capsular axis can be completed easily after the decompression. JEPTO act on the principle of the vacuum created over the anterior capsule of the lens and applying thrust over the anterior capsule by nitinol ring, and after that the vacuum was released and anterior capsule was done.
Luminescent cataract with a vision of
Just
perception of light in the left eye.
The problem created by famous renowned surgeon, which has to face a great problem during the JEPTO capsular axis because the vacuum was not being released after the capsulotome. In other hand, how easily the capsular axis is being done after creating a central round hole through the swing needle capsular axis, capsulotome, and axis are being done comfortably without any difficulty.
Dangerously at the 6 o'clock position, tubing, and lo behold, this was visible with the gush of fluid and viscoelastics through the side port. The vacuum was released, and to my relief, I was able.
Swing needle microcapsulotomy with circular round hole puncture the anterior capsule along with the pressure decompression is the simplest technique which enable to prevent Argentinian flag sign with very little effort and much easier surgical maneuver. Swing needle microcapsulotome is yet highly effective novel device to open up tense anterior capsule and accurately decompress the bag prior to initiation of capsular axis of desired side with higher level of efficacy, safety, and enable to prevent Argentinian flag sign with very little effort. It can safely be used in comparatively shallow anterior chamber where a safety margin is less with japtocapsular axis, no or minimal learning curve. It can safely be used in comparatively less dilated pupil, no chance of vacuum-related problem, and last but not the least, the operational cost is zero. Thank you. My special sincere thanks to Dr. Rajendra Prasad, RPI Center, Delhi, Dr. Bharti Kashyap for including me in this session, Dr. Arvind Maurya, Dr. Ashish Syam for remarkable guidance, and AIOS for giving me the opportunity. Thank you.
I'll just take few seconds only. The latest way of handling such cataract, as advised by Professor Harbanslar, I tried in many cases. Believe me, I love this Panchorexis, which I started in 2014. What he does is, after doing all those, putting the air, putting the trypan blue and this thing, you massage the anterior capsule. You massage it, and it goes back, and then there is no urgent infraction. Please try it. There is no harm in trying. That's wonderful. Sir is here. Sir, I have done so many cases.
Sir, one thing, sir. Sir, one thing before 1 minute I would like to take.
Why I am distracted? You very well know. Anyone will be.
Ma'am, 1 minute.
So,
I had been trying that method, sir, you told me, that massaging and
sir,
taking.
आइए ना conclude कर दीजिए.
But that's a very rare number, I would say. In one case is what happened when I was going along the mid-periphery, it suddenly started running out. So this Zepto method is a foolproof one.
No, Zepto first of all is not available now. If you are charging from the patient, you could be in any trouble anytime. Because it's not available in Indian market. I have not seen it. From where have you imported? Have you imported? Tell me honestly.
It was, I bought it
have
from
you imported? Because I had a talk with David Chang, himself was trouble. He gave me his phone number and asked his company to contact me. So I'm saying that if some of you are charging without having Zepto available in India, you may be in trouble. If you have a Zepto or not, I don't know. But at the same time, it is not available for not nearly a year. So I don't think anybody can stock so much. Thirdly, if you have not done a massage, and go recheck your video. One patient I had where it ran away, I saw that the capsule got stuck with the forceps, and when I tried to draw the forceps, capsule was stuck there, it went out. So if you do a proper massage, I have not seen in last 5 years in a single patient going out. And not only Bharti, just when I came to Jharkhand, I talked about it. I met 2-3 people more, sir. जब से आपने बताया ना, उसके बाद से आज तक कोई rexis बाहर नहीं गई. Pockets? Yeah. No, intralenticular pressure decreases. If you put a salt in a water, the level will remain the same. You will get your 2 have I got a separate volume. You squeeze the tomato, it becomes soft.
I landed into one of the pockets.
Anything, because the solid and liquid, when they mix together, the volume goes down. Separately, they have more volume. So massage anything, it will become soft.